Eclampsia occurs as a complication of worsening preeclampsia. The blood pressure is high with associated proteinuria and convulsion or eclamptic fit, which is similar to an epileptic fit with tonic and clonic phases followed by coma. So the fits are often repetitive and of short duration, from 60 to 90 seconds. The causes are like the causes for preeclampsia, which is unknown, but it's more commonly associated with primigravidi, maternal age, less than 18 years or more than 35 years, multiple pregnancies, hydatidiform mole, medical disorders like polycystic ovaries, chronic hypertension, diabetes mellitus, kidney disorders, first pregnancy with a new partner, and previous history of preeclampsia, family history of preeclampsia. The signs are fits and unconsciousness. Those are the symptoms, and the signs that are usually elicited are convulsions, coma, elevated blood pressure, and proteinuria. The investigations are FBC, blood film for malaria parasites, urinalysis and culture, blood urea and electrolyte, ultrasound examination of the uterus to exclude multiple pregnancy or molar pregnancy. Main treatment objectives are to protect the patient from injury, to prevent further fits, to lower the blood pressure, to monitor for organ failures, for example, renal, as well as obstetric complications like placental abruption and fetal distress. Also, to prevent maternal mortality, to deliver the baby when the mother is stable. Non-pharmacological treatment: you lay patient in the recovery position, you prevent a patient from falling, you avoid restricting patient to prevent limb fractures and joint dislocations. Also, do not put anything in the patient's mouth to prevent tongue biting. Maintain the airway by either holding up the chin or, if possible, insert a mechanical airway to hold tongue and to hold down the tongue. If postpartum and the patient remains unconscious for a long time, consider turning them every hour to prevent sores from developing. So artificial respiration may be required following general anesthesia. After the fits, you obtain IV access and catheterize the patient. If no further fits, and after patient is stabilized, you deliver the fetus by the most appropriate method to ensure safety on both the mother and the baby. The mode of delivery will depend on the patient's clinical condition and the status of the fetus and her preference. Pharmacological treatment: fluid replacement. You give sodium chloride 0.9% IV or Ringer's lactate IV, a maximum 1 liter in 6 hours or 4 liters in 24 hours. Treatment of convulsions: you give magnesium sulfate IV 20 milliliters of the 20% solution, 12 grams, and administer slowly over 5 to 15 minutes. And then magnesium sulfate IM 10 milliliters of the 50% solution, 5 grams into each buttocks, with a total of 10 grams. The treatment of recurrent convulsions: if fits recur within 2 minutes, you do not repeat magnesium sulfate. And if fits recur after 20 minutes, you repeat magnesium sulfate IV. More than 70 kilograms, you give 20 milliliters of the 20% solution, that's 4 grams. Less than 70 kilograms, give 10 milliliters of the 20% solution, as 2 grams once. So maintenance, you give magnesium sulfate IM 5 grams in alternating botox every 4 hours to 24 hours after the last seizure or delivery, whichever is later. Toxicity to magnesium sulfate presents as slowing or arrest of the heartbeat and the respiration, and also loss of deep tendon reflexes. So before giving a dose, ensure the following parameters are normal. So the respiratory rate is more than 20 to 16 breaths per minute. Urine output is 100 milliliters or more over the previous 4 hours. The presence of knee jerk or other deep tendon reflexes. And you check in case of toxicity to magnesium sulfate, you give assisted respiration. You administer 10 milliliters of 10% calcium gluconate IV slowly in suspected magnesium sulfate toxicity. The treatment of convulsions not responding to magnesium sulfate, you give diazepam IV 10 milligrams slowly over 2 to 3 minutes, not exceeding 2.5 milligrams every 30 seconds, and then more than 60 kilograms 5 to 10 milligrams 8 hourly, less than 60 kilograms 5 milligrams 8 hourly. Do not exceed 500 micrograms per kilogram in a day or 30 milligrams in 24 hours. You treat treatment of hypertension in eclampsia, give hydralazine IV 5 to 10 milligrams starts over 5 to 10 minutes, and boluses can be replaced every 20 to 30 minutes. The BP should not fall below 140/90 millimeters mercury. And then you give hydralazine IV infusion 20 to 40 milligrams in 500 milliliters of sodium chloride, 0.9%. The rate of infusion should be titrated against the blood pressure readings. If the hydralazine infusion runs unattended, profound hypotension may ensue. So hydralazine IV is best given as multiple bolus doses at 20 to 30 minutes intervals, so the BP is reduced, and the diastolic pressure should not go below 90 millimeters mercury, as placental perfusion may be impaired with resultant fetal distress. Or you can give labetalol IV 20 milligrams starts over at least 1 minute, and then repeat at 10 minutes intervals if the BP remains more than 160 110 millimeters mercury as follows. So 40 milligrams 80 milligrams 80 milligrams boluses to a cumulative dose of 220 milligrams. And when the BP is less than 160 110 millimeters mercury, starts an infusion of 40 milligrams per hour. You double the infusion rate at 30 minutes intervals until satisfactory response, or a dose of 120 milligrams 160 milligrams per hour is attained. So referral criteria. So you refer all cases of eclampsia immediately to a hospital or obstetrician in a facility with operative capacity, and as much as possible set up an IV line for sodium chloride 0.9% or Ringer's lactate, and administer the IV dose of magnesium sulfate slowly at the health facility. So follow this with the IM dose and accompany the patient to the referral facility. And if the IV dose cannot be given, you simply give the IM dose of 5 grams into each buttocks and transfer.